Want to also beg your patience with our staff. We are, I think, continuing to hone in hybrid meeting structures. We have quite a bit going on in person at the building. You don't see it. For most of us, we are all virtual, but we have staff that are in our physical space in the building because we have begun to have what we call hybrid meetings and have people both in person and online. So please, we just beg a little bit of patience and grace as we continue to hone in the technology. Before I take roll, I want to also welcome a new member. Jane Beyer is here from the Office of the Insurance Commissioner. Jane is replacing Molly Millette on the board, and Jane has served as a senior health policy advisor to Washington State House of Representatives for, oh gosh, Jane, you've been around forever. Let's see. So she's with the insurance commissioner, Mike Kreidler, since January of 2017, and she was legal counsel to Washington State House of Representatives for 20 years prior to that, working on a broad range of health and human service issues. She also served as the Medicaid director from 1995 through 1998, and she was also the behavioral health commissioner from 2012 through 2015. I personally got to know Jane when she was also with the Milbank Fund, and she is just nationally known. So Jane, we are so glad to have you on board with us on our board. And if you want more about Jane, there's more that we provided you. Welcome.
Thanks, Sue.
You're going to be a great addition. And now I know I've made you feel old for all those years, but you can just rest assured that Eileen and myself and Margaret and others have many, many more years ahead of you. So it's great to have your perspective.
Actually, not that many, but
there you go. Right. We're all in that. We've been doing this a long time.
Yep.
I want to provide a brief overview today of the agenda. What we'll do is we'll begin with a roll call, but as I expressed at our last meeting, we want to take the opportunity to just share a little bit about each other. So when your name is called, please share a fun summer activity that you've planned. And after roll call, we will have the April meeting summary to approve. And after that, we'll have Joel Dielman from the Institute of Health Metrics and Evaluation. He's here to present on our new grant-funded analytics support initiative, which is great. We're really thankful to the Peterson Center and the Gates Ventures for this grant. And we are really excited to work with IHME on an analytical strategy initiative to better understand the levers that the cost board can implement to help drive down the cost growth curve. Under the second tab in the cost board, there'll be materials in the announcement. Then we'll hear public comments. And after public comments, we'll discuss 2 legislative draft reports for board feedback and adoption. Then we will have a report out from Dr. Zerzan, our chair of our Primary Care Advisory Committee. She's going to present the committee's recommendations on the primary care claims-based measurement. And I, as always, ask you board members to jump in, ask questions, provide feedback, and it just helps make for a richer discussion and ultimately better recommendations from our board. So, and as usual, I want to thank you all in advance for your time and efforts that you put into this work. And don't forget, as I call your names, we're going to share that fun summer activity that you've planned. And to get us started, I will tell you that my summer plans were a little upended by some surprise, unexpected knee surgery that I had to have when I tore the root of my meniscus in my knee. And so I am enjoying some gardening off my deck and just really concentrating on healing. And boy, have I been doing some secret customer shopping with healthcare through this journey. So that's what my summer plans. I'm going to have a very sedentary summer, but I'll be sitting and gardening in raised garden beds. So now we're going to move on to the roll. So Jane Byer, are you here? And what's your fun summer activity?
I am here, and let's see, after attending the National Academy for State Health Policy meeting in August in Boston, we will be biking and hiking in Vermont for 10 days.
Wonderful. Wonderful, wonderful. I'm going to be living vicariously through you. Eileen Cody, it looks like you're just coming back from a safari hunt.
No, that was a few years ago. Yeah, I'm here and I don't have a plan for the summer, but I have booked my next vacation. We're going to Israel, Egypt, Jordan, and Turkey in the fall.
Wonderful, that counts. Planning for that sounds great. We'll be looking forward to hearing about that. Lois Cook. I don't see Lois on yet. Staff, will you let me know when Lois jumps on? Bianca Frogner, are you here?
I am here. Hello. Good to see everybody. Let's see, my fun summer activity. I'm part of a boat club called the Freedom Boat Club, and you can take a motorboat out, and I will be taking out a motorboat to go up to the San Juan Islands. And so that's going to be an adventure. I'll be doing that right after July 4th week. So looking forward to doing that with my family.
Wonderful. Oh, that sounds great. Leah Hole Marshall. I think I saw Leah on. Leah's not in yet. All right, we'll watch for her as well. Jody Joyce, I know I saw you, Jody.
Yes, I'm here. Hi, I'm Jody. I'm up in Bellingham. One of the summer things I'm looking forward to is going to the Morton Loggers Jubilee in August. It's like one of the first logger jubilees that happened anywhere. And I think they're on like their 80th year. My brother lives near there, so I'll be visiting my brother for a weekend and going to that. Kind of on the way from I-5 head to Packwood, and it's halfway there.
Wonderful. Oh, I love this. Everybody's venturing out. All right, Mark Siegel, are you with us today? I do not see Mark on. Let's move on. Margaret Stanley. I know I saw Margaret.
Yes, well, I'm going to have a brief trip to Idaho in July, and in September, I'm going down to Ashland to see some plays.
Mhm.
Wonderful, wonderful, wonderful. Kim Wallace.
Good afternoon, everyone. See, my fun summer activity will be a road trip, family road trip, and with a couple of kids. And so I don't know how adventurous that will be. Hopefully not too adventurous, actually. And Jody, I guess maybe you can consider whether you're going to enter the log rolling contest or something like that.
The lawnmower races might be more my caliber.
Okay.
Oh my God, they both sound like so much fun. I think the road trip sounds good too. Carol Wilms. Carol, are you on? I do not see Carol yet. And then last, Edwin Wong.
Hi, I am looking forward to continuing my newly picked up pandemic hobby of Frisbee golf at many of the really fantastic Frisbee golf courses, disc golf courses in the North Puget Sound area.
Wonderful. I've always wondered about that sport. You're going to have to brief me sometime. That
Really
sounds
fun.
like fun. I hear like full moon Frisbee golf is the rage too with kids, but sounds like injuries waiting to happen for we old timers, but that sounds wonderful. Great. All right. Well, staff, please keep us alerted as any of our board members that are not in attendance join. Margaret, you have your hand up. Go ahead.
Since there are a number of board members missing, I just thought I'd mention that I had difficulty getting onto Zoom with this new webinar format and finally did, but they may be having trouble too.
Thank you for that input, Margaret. Can I ask staff to please send out some emails to those that aren't in attendance? Because it is strange that we are missing Leah and a few others that we were expecting.
Leah did let me know that she'd be running late today.
Okay, perfect. All right. Thanks for that information, Margaret. We will try to improve on that next time. board members, we are going to move forward. If you will join me in going to the third tab in your board book. And Mandy, thank you for putting up the minutes on the screen. As a note, the recording of the last meeting is posted on our webpage for reference. And we're going to use the consensus process for a vote on the approval of the meeting summary. Is there any discussion of the April meeting summary of any proposed changes? Kim, go ahead.
Yes, I had one small thing, but it might be of significance. On page 5, I think it's under the benchmark section. Right there, yes. In the first paragraph there, third line down, there's a, let's see, I'm sorry, second line, the end of the second line, there's a phrase, cost growth analysis. And I actually think that means cost, it should read cost driver analysis.
We can make that change.
Great. Thank you for that input, Kim. Any other notable changes to the minutes? If not, is there a motion to approve the minutes?
I move we approve the minutes as written, or with the change.
Great. Is there a second?
Second,
Thank you, Margaret. All in favor, say aye.
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 Great. And any opposed? All right, the motion is approved. All right, now I would like to welcome Joe Dielman from the Institute of Health Metrics and Evaluation. Joe's gonna lead us through the exciting initiative with the goal to develop the Washington-specific analysis of cost growth trends and other data that's going to assist our board with the development of the healthcare cost mitigation strategies. This is really a first in the nation opportunity between the Peterson Foundation and IHME. So we are, and Gates. So we are really excited about this. And I'm going to turn it over to you, Joe, and you take it away. And
Great.
your slides are behind tab 4.
Thanks, Sue, for the warm welcome. Nice to see some familiar faces and to meet the rest of you. It's a privilege to be able to present today and to talk about this. I think according to the agenda, I have about 45 minutes. And really most of what this is a kind of an introduction and a meet and greet and an opportunity to take some feedback from the board. So the following slides are really just an introduction to this analytical support initiative that a number of us have been talking about for a long time, myself and folks at the HCA, as well as some funders at Gates Ventures and the Peterson Center. So really excited about it and excited to kind of bring you into the circle and hear any feedback today. So if you want to click to the next slide. So as far as kind of an agenda for the day, it's kind of broken up into 3 pieces. The first is just an introduction to myself, kind of what we do and why I'm here today. Then we'll, that's really the bulk of the conversation. I'll end with then kind of sharing some next steps and then really turn it over for discussion to get feedback from this group. I should say too that I am great with taking questions as I present too. So if things are unclear or any concerns come up, please interrupt and I can try to clarify. But then we'll have time at the end for sure for more discussion. Next slide, please. So this is an introduction to myself. It's really nice to meet all of you that I don't know. I am an associate professor at UW in the Department of Health Metric Sciences. And really for the last dozen years almost, I've worked at the Institute for Health Metrics and Evaluation, where I lead the resource tracking team. I'm an economist by training, did my PhD at UW, which is how I got connected to IHME. And really most of my work has focused on resource tracking, which is not so much about causal attribution, although we do some of that, but it's more about describing where the money in the healthcare system comes from and where it goes. And so we've done a lot of projects that I'll talk about in a moment that are at the national level, but really for the last 3 or 4 years, our big push has been to take our research and look at the subnational level, look at specific states, look at counties, And I should say maybe I should have started with this. The work really began on a global level. A lot of what we do mirrors or reflects work that we've been doing for many years, looking across countries and making comparisons of broader health systems. So, next slide. So HCCTB, I'm not sure how many people are familiar with it. We became a little bit more famous during COVID when we were making a lot of forecasts, but HCCTB is at UW. It's an independent research center. It's been around at this point for just about, I think we're more like 17 years, but we do have about 450 employees scattered really throughout the US. We're pretty much virtual 100% now. There's 30 faculty members that are full-time at HCCTB in different departments across the university. And what I do think is the unique thing about the Institute for Health Metrics and Evaluation is where it's kind of really found its niche is dealing with bad data. And one can describe or define bad data however they like to. In some cases, that's sparse data that might be measuring outcomes of health conditions in low or middle income countries where there's not vital registration, there's not insurance claims, but you need to use novel statistics and methods to make well-informed estimates with confidence intervals of what's going on. We've taken a lot of that knowledge and brought it back to the US, and that's a lot of what my work is focused about 50% on just thinking about healthcare financing in the US. So the next slide introduces kind of where this project came from in the first place. And so the slide here is just highlighting a report that Michael Baylett and Baylett Health put together and published about 2 years ago. And the report was funded by the Peterson Center and Millbreak Memorial Fund, so familiar folks. But it was, for me, it was really validating to see this report come out because in many ways, it felt like Michael and his team were describing the kind of a vision for the same way that we saw the world, which is that, some basic data insights can actually go a long ways. That's not to say that, more sophisticated causal analyses aren't appropriate in all kinds of important circumstances. But if you look across the healthcare system, the point that we were making, and that I think this report makes nicely as well, is that there's some real basic information that we don't know either. And some of that basic information is, just at a kind of rolled up level. Where is the money in the healthcare system coming from? Where is it going? Who's it being spent on? We know it's going up. That's very well established. We know the US spends over $4 trillion on healthcare when the world spends just over $9 trillion. So, to put that into context, we know there's a problem as far as enormous spending goes, but there's a lot less information, especially, across the whole country or across a single state about what that money is being spent on. And so that's where I think this report does a nice job of just saying, hey, there's some basic questions that every state should be able to answer if they're serious about curbing cost growth. And those kind of three basic questions are how they organize their report, and they're on the screen here. Where is spending problematic? And by that, they, kind of mean it's going up dramatically, or there's amazing variation that can't really be explained with the underlying population. The next question is, what's the cause of the problem? Why is it going up so fast here? Or why is there amazing disparities, across this sets of population? And then the last question is, who's accountable? And that, I think, lends itself to kind of an action perspective of what can we do about it? Do we want to make a normative statement about the growth here in this spending? And is this a place where we can curb cost growth? Or is this a place where the, disparities highlight that there is a marginalized population that isn't getting the care they need, or alternatively, that there is excess spending on a population in this case? So these, very basic questions in some ways nicely frame the work that we've been doing over the last decade on this project. If you could go to the next slide. Oh, I think that was backwards. Oh, that's backwards again. Awesome, cool. So in that report is essentially this table. And this table, again, nicely frames work we've been doing for a while and nicely frames the way that we see this analytical support initiative. The idea of the report and of this table is that, again, these are some basic metrics that are valuable for, in this case, the Cost Transparency Board to be familiar with and to be able to zoom in on and kind of break apart in, at least at the beginning, in a fairly just descriptive sense, knowing which parts of the healthcare system in Washington State are growing the most. Which markets is it? Is that growth equitable across the entire state, or are there pockets where growth is much higher? What are the service categories that are going up the most? What are the health conditions that seem to be driving that? There's a fair amount of good information on the underlying disease prevalence or epidemiology within the state. I think oftentimes the health financing work is lagging that. We know the diseases that are leading to mortality and morbidity within the state of Washington. We don't always know the diseases that we're spending our healthcare resources on. So again, asking these kind of basic questions of what are the health conditions that we're spending money on? How is it changing over time? And then finally ending with important look at demographic variables and what is the age, what is the sex, to what degree can we break out spending and utilization by race and ethnicity, as well as some other characteristics. So that's kind of the very first step of the project, is to say, let's build a data set that can answer all of these questions and can answer them at a pretty granular level, but still do so in a comprehensive way. And so we don't want to do this just for private insurance, or we don't want to just do this for Medicaid, but we really want to do it for private insurance and out-of-pocket spending, and for Medicaid and for Medicare, and we want to do it for hospital care and outpatient care and pharmaceutical care. Ultimately, we want to do it for all these different slices, so that we can put it together in a way that tells us about the whole state, but we can also break it apart and dig deeper into kind of specific areas. Again, looking for outliers, looking for trends that we can't otherwise explain. So that's the first part of the project. The second part, if you can go back one quick second. The second part is then to do a slightly more formal analysis of identifying the growth. So really looking at the time trends. We've done work on this in the past where we look at key drivers. This relates to demography and utilization and disease epidemiology. And so again, that's the kind of the same framework. That's the parts of the project that we have relatively well defined. As number one is kind of creating a data set. And then number two is really, frankly, just studying that data set. And this is where I think we hope that there's a fair amount of back and forth with the Cost Transparency Board, because in many ways, we hope that this data set can be useful to you. And really want to follow your lead as far as answering some of the questions that you're most interested in. And so now I'll go to the next slide and talk a little bit more about what this analytical support initiative is. And so to be clear, it's essentially a 2-year sole source contract between the HCA and IHME, the IHME part led by my team. The HCA was externally funded by the Peterson Center and Gates Ventures to do this. So this grant funded, and in some ways the Peterson Center and Gates Ventures kind of pulled the HCA and IHME together to say, what could you guys do to take some of the research that my team has been doing over the years and try to make it a little bit less academic and align it with the goals of the Healthcare Cost Transparency Board. And so the objective here is, straight out of the grant documentation, and I'll let you each read it yourself. But the point really is to ultimately be a support unit, a support initiative to try to, again, build a foundation of data that can be useful to the Cost Transparency Board, a set of estimates, and then to, in some ways, propose some sort of analyses that go with that, the start being that cost growth that we talked about, or that I mentioned a minute ago. And then in addition to that, essentially following the lead of the board and identifying the pieces that are of most interest to the board that we can use this data set to explore. So I think the next slide Oh, this is the last slide on just kind of an overview of the analytical support initiative. So just to be kind of aware of the calendar, I kind of mentioned that it's a 2-year project. Written into the contract that IHME has with the HCA are a couple of key deliverables. So I'll quickly walk through those. We're putting together an analytical strategy at the moment. That essentially is a kind of initial outline of what we plan to do over the course of the 2 years. Then we will tailor some of the research that we've done previously to look specifically at Washington State. And so we have, I think I kind of mentioned that this broader project that I get to lead at IHME has been going on for almost 10 years. And we have made a bunch of estimates at the county level, but not really dove into looking at Washington State specifically. And so the very first part of the project is say, let's take this data set that already exists. It's a little bit out of date, but can we get some important lessons that would be useful to the Healthcare Cost Transparency Board just from the existing research? While we're also in the process, and this goes on to the next piece, of incorporating more up-to-date data from the Washington All-Payer Claims Database, as well as a number of other data sets. And so by the time we get to October 2024, the hope is to start now having a more up-to-date data set. That's the kind of new data set that we're building. And from that, really starting to develop some recommendations to identifying next steps for analyses. And then finally, at the end of the project, at the end of the contract, delivering on a cost drivers report where we've used this data set to essentially explore what are the cost drivers, and in addition to that, what are the key things that the Cost Transparency Board would want us to dig into more fully. And then the last bullet point on this slide is it's purposely dynamic and collaborative. Certainly the way that I do research is more in some ways as a generalist, and look to the board to say, you have the expertise on some of the questions that you're asking. And it's, especially as an academic sitting at a university, it's pretty hard to know exactly what those are. But I think we're pretty good at answering them when we know what the questions are. And so this in many ways has been a contract that's meant to be a little bit open-ended, and to say, let's figure this out as we go. Sue kind of mentioned it's the, as far as we know, the first in the nation to have this kind of framework where an academic analytical support group is kind of joining a group like the HCA to support the Cost Transparency Board. So we do think it's novel, and to some degree is something we're going to figure out as we go. And so hope that you guys will be a part of that journey, and hope that it can be useful to the Cost Transparency Board. So I think that's the last slide of introducing the Analytical Support Initiative. The next set of slides, and this is really the last kind of part of the presentation, is just an introduction to what we've already done. And I think this is, oh, Bianca, jump in.
Can you hear me? Okay, sorry. Thanks, Joe. Sorry, before you start diving into the details here, I could just use some clarification. I don't know if you're the one who would do it or if Sue, is to help me understand how this work relates or overlaps or complements the work that OnPoint and NASH and others are doing. I'm just having a little hard time understanding kind of how this fits in or what the plan is relative to the other groups who have been doing some related work.
Yeah.
Oh, go ahead, Sue, please.
Let me start from a high level, and then Joe, I'm going to ask you to piggyback, but really great question. And when this initially surfaced, several other states were looking at this as well, because we have a pretty big divide sometimes between some of the more epidemiological data and some of the finance data. Just today, Milbank had a fabulous session. I don't know if any of you listened in, on trends in financing and ownership of the US healthcare system, and their big med spread and their recognition of how kind of the uber financialization of healthcare system continues to go forward means we need other explorers with us to really understand and suss out data, and to really have folks working together, looking at it from different perspectives. And so that will increase the transparency. It will hopefully build some peer pressure with other states and within the healthcare system, hospital boards that are starting to say, wait, why do we look differently? Or why is that happening different in this part versus this part? So it gives us another perspective. You know, I'm such a nurse, and I always think about this is so moving beyond just kind of x-rays, two-dimensional, but into like that MRI, or we're getting kind of more multi-systems. So Joe's group really brings more of that to us, and it will add, I think, extra efforts around our understanding and really getting closer to the cost driver and then the policy solutions that need to happen. And I think you can't understate some of the exploring and digging that we need to do. You've already seen that with your role on this cost board, but I just learned today that in 2010, there were 123 private equity investments made in the US healthcare system. And we are now as of 2020, the data was, well, we were over 1,200 investments of PE. And so we're just trying to figure out where the heck is all this going and why are costs continuing to go up and up and up. And so Joe's group brings us kind of more ability to cross data sets and to understand them, and to really, they're just extraordinary data scientists and partners in all of this. Joe, over to you.
Yeah, thanks, Sue. Thanks for that. I think, Bianca, I think it's a great question and kind of an obvious one, because I do think there's lots of people, even just organizations working with the board on these same questions. It certainly is intended to be complementary. It doesn't replace what OnPoint is doing. I think we do bring our own kind of angle on it, and I hope that at the end of that is what's beneficial, is that OnPoint will produce something and we produce something, and they're not meant to compete with each other. They're also not meant to contradict each other. We want them to be aligned. We don't want two cooks with very different perspectives on where Washington State is. But the hope is that the data set that we're building is different and can answer different questions. And I'll kind of get into a little bit how it's different in a moment as I kind of describe it a little bit more. Yeah, I think I'll leave it at that. But certainly complementary is the intention.
And that's helpful. And perhaps as you move into the data, it'll be more clear kind of where the differences are in some of the data sets that one might build. And I mean, certainly I'm a data person, so I love data. I mean, don't get me wrong. You know that too, Joe. He would say, I guess my question is then, I guess as a board, it'll be up to us to kind of sort out then who should be answering which one of these questions, or who will be helping to guide which group will answer which set of questions, given that there are lots of complements and some overlaps in sources. Any sense of process, or maybe we'll figure that out as we go along.
Absolutely, Bianca. We will continue that conversation as the data evolves and as the groups work together and our advisory committees help us kind of glean more insight. I thought I saw Lois's hands up. Was somebody else's hand up? No, okay, Joe, back to you, unless there's other comments or questions.
Great.
Back to you, Joe.
Great. Thanks, Bianca. So let me describe a little bit the work that we've done to date. And, you know, I kind of always present, it's the sort of stuff that's easy to present at an academic conference, because right now it's been kind of one step removed from the direct policy component. I think this is where we're really excited to get to work with the Cost Transparency Board and make it more actionable. But the data set is really the foundation of what we've done. And so what I'm going to talk about right now is about half of it is published and publicly available, and about half of it is kind of still in the works and should be available in the next few months, but is really in the final stages. So we refer to this project as DEX. It's the Disease Expenditure Research Project. And Bianca, back to your question about like where there's similarities and differences, you know, I do think one of the unique things that IHME does and this DEX project does is add a kind of epidemiological framework on top of a health financing perspective. And so what you see at the bottom is these 5 green boxes. The idea is, and this is our existing project, not so much the one focused on Washington, is to take the, the big number, the $4 trillion of spending in the US healthcare system, take out the stuff that is public health and really focus just on personal healthcare spending. And then break it up and ask the question, where's the money coming from and who's it being spent on? And so by that, we really mean applying these 5 different frameworks. And so we have a demographic framework that focuses just on what are the ages and the sex of the patients, the people that resources are being expended on. What is the disease framework? And I think this is something unique to our group, that we have kind of a set of 161 health conditions that we focus on. That 161 health conditions is mutually exclusive and collectively exhaustive list. So every disease that has healthcare spending falls somewhere into one of those 161 categories. A lot of them are relatively focused, and some of them, because it needs to be comprehensive, end up being a little bit larger. So, for example, we look at 26 cancers, and then there's also a category that's like all the rest of the cancers, which I think from an action perspective is hard to use. But again, the point of the analysis is to be comprehensive. We don't want to leave any dollar out. We want to take each dollar and kind of ascribe it to, again, just like we would an age and sex of the population, we want to be able to do the same thing for a health condition. And so again, our framework is 161 of those. We look at 7 types of care. So that includes in-hospital inpatient, nursing facility, retail pharmaceuticals, dental care, emergency department care, home health care, and ambulatory care. So those are kind of the 7 that we focus on. We, at least for all of our public research, focus on aggregating payers into 4 payer categories. We have Medicare and Medicaid, each separate, and then we have all private insurance lumped together, and then we have the uninsured, and then we those are kind of our primary payers, but then we also look at the actual payers within those categories. And then lastly, all the work that we've published to date on this is at the national level. And what we've really been doing over the last 3 or 4 years is taking that to the subnational level. So everything we've done at the national level, we're now doing for 3,110 US counties. And the key is, like, by the time you put together these 7 frameworks, you end up with about, and there's uncertainty and a wide variety of parameters that need to get estimated, but in the end, it's about 8 billion estimates. And so it's a very big data, kind of broad empirical challenge of saying, how do we disaggregate all of the healthcare spending in the country into these frameworks? Again, to know where it's coming from and know who and what it's being spent on, where it's being spent. And so we feel like the strengths of the project is that it's comprehensive, that's inclusive of really all the spending, not just one payer or not just one population, but it really is meant to be comprehensive or inclusive across the country. That it can connect to existing population health outcome estimates. And so, we find that when connecting with either epidemiologists, medical doctors, administrators in hospitals, and policymakers, people tend to think in terms of diseases. Health economists don't always think in terms of diseases, but doctors tend to think in terms of diseases. Policymakers tend to think in terms of interventions for specific diseases. And so we found that having a data set that, again, can connect back to diseases, can look at specifically diabetes type 2 and ask questions about, per prevalent case, how much are we spending in King County versus Pierce County, and what explains some of those differences? Those sort of questions is what having a data set that has the utilization and spending alongside the disease prevalence is really valuable, because you can start to look specifically at utilization per prevalent case or spending per prevalent case. So that second strength is really the marriage between prevalence and mortality and morbidity data, as well as connecting that with the financing data. And then, as I already mentioned, I think lots of people tend to think in terms of diseases. So, yep, Kim, go ahead.
Hello, just a quick question about the disease framework and health conditions box. I guess I was just wondering if the spending on diagnostic work, testing, et cetera, with that is, there might not be a diagnosis, but of course, we're, kind of looking for one. And is that spending is in that box there?
Yeah, so it is in there again, because the goal is to be comprehensive. And so it kind of depends on if it's an inpatient or an outpatient claim. Inpatient, ultimately, we see a lot of diagnostics, but in the end, there is normally a diagnosis. And so in that case, we are able to attribute that spending to what was believed to finally be the diagnosis. In an outpatient setting, that's harder because there's not always a diagnosis in a single visit. Same could be true for emergency department. So in those cases, we have ICD coding associated with the claim that we would then attribute it to. And then we also have a number of health conditions that we say, well, this is not really health burden. And it could be normal diagnostics that someone has a well care visit. And so we have a category that is, well adult care. Or another one that I think is important to recognize is we have, labor and delivery uncomplicated, which, is not health burden, but it's, a lot of money. And so again, being able to back out every dollar and kind of fit it into one of these categories is the objective.
Okay, thank you. That makes sense. I was going to ask about that screening and things like that, and I think maybe perhaps it's just the label disease framework that implies. Okay, thank you.
No, I think it comes from, and this is for those of you who know IHME, there's the global burden of disease is the kind of pinnacle project. And so our framework in some ways starts with that research. But of course it needs to add things because while diseases are what lead to health burden, there are a lot of things that lead to health expenditure. And so you're right, Kim, that the disease title is probably not the right one. And in some ways you can think of it, those of you that are, clinicians or have close connection to providers, part of the data that we're using is from, the diagnosis on claims. And so, everything tends to have a diagnosis. In many cases, there's many, and at another time, I'd be happy to share like kind of how we do that in a more granular level. But that's kind of the system. So why don't we go to the next slide and people can keep jumping in with questions as they have them. The next series of slides are essentially estimates that are already publicly available. They're essentially illustrations of what we've done with the data sets that we've built previously. And so this is a square pie chart. If you're not used to looking at square pie charts, it's a lot easier to look at a pie chart that has 154 pieces. If they're squares and rectangles, a circle doesn't work well with 154 slices. But this is healthcare spending at the national level in 2016, looking at all the types of care that we look at, all the age, sex categories, all the payers, and in today's dollars, that's $2.7 trillion. And the bigger the box is essentially more healthcare spending. And the darker the box is the higher the growth rate at the national level. And so the big boxes and the dark boxes are the one that should immediately jump out to you. I think some people are surprised that we spend in the United States more resources on healthcare on low back and neck pain than any other health condition. Diabetes is number 2 and ischemic heart disease is number 3. The difference between diabetes and low back and neck pain, those are very dark blue boxes. And the reason they're so dark blue is because the annualized growth rate over 2 decades for those 2 diseases is, almost off the charts, relative to the other health conditions, where ischemic heart disease over the course of the last 2 decades, really the growth rate hasn't been very high. When we think about spending more and more money on healthcare in the United States each year, it's not because of ischemic heart disease. And if you go back to the late 90s, ischemic heart disease was by far the biggest spender, whereas now things like diabetes, low back and neck pain, other musculoskeletal disorders, dementia, some of the treatment of modifiable risk factors, those are some of the diseases that jump out today. Just to orient you to the figure, it's all meant to be very customizable and interactive. So if you go to this viz, you can kind of see it and you can say, oh, I'm only interested in hospital care. Let me click a button and the whole pie chart rearranges to see hospital care. or I'm only interested in Medicare, I can switch it and see Medicare or Medicaid for that matter. Why don't I go to the next slide, because I have a few of these. I don't want to spend too much time on any one of them. This next slide is research that we published that was looking at growth in annual spending from 1996 to 2013. And so this is right now broken up by type of care. So it's just looking at 6 types of care. And to be clear, the x-axis is the increase in annual spending on that type of care. And so to maybe say it a little bit more clearly, between 1996 and 2013, the annual spending on ambulatory care increased by more than $300 billion. So it was the type of care that had the largest increase. Inpatient care, hospital inpatient care had the second largest increase, with about $260 billion increase in annual spending. What's cool about this figure, I think, is it starts to break down what, across these 5 key drivers, what was the reason for those increases. So again, this is at the national level, but it starts to kind of paint a picture of why do we see these increases. And you can see that we've broken it into 5 different categories. There's the increase in the population size, the increase in the population age. We know that the country as a whole is getting older. We also know that prevention is a major part of the healthcare system. And so have we done a better job of preventing disease, or has the age standardized incidence and prevalence of key diseases gone up? And that's, ultimately we're less healthy. Is that why we spend more? Is it that there's more utilization, or is the price and intensity of care gone up so much? And what you can see here is, something that I think doesn't surprise any of you, is that the red is a major part of this story. Increases in price and intensity is leading to a major part of the increase, although it's leading to the largest impact in inpatient care, hospital inpatient care, and less so in outpatient care. And in outpatient care, we see that really that's ambulatory, that top bar. That part of the story is about utilization, and part of the story is about price and intensity. So it allows us to start to understand those increases over time. Jane, do you have a question?
Yeah, on pharmacy spend. So I see you've got retail pharmaceutical broken out.
Yeah.
But when we think about what's driving prescription drug spend these days, it's specialty drugs. Specialty drugs are often physician administered.
Yeah.
So would those drugs be sort of lumped into the service price and service utilization in inpatient and ambulatory care?
They would. Yeah, it's not necessarily the way we want it. We actually started a study that we weren't able to finish a number of years ago, essentially taking all pharmaceuticals and lumping them together instead of just the retail pharma. So right now, anything that is physician administered is going to fall into one of those other categories. Normally, it's going to be ambulatory care or inpatient care. And so we can pull some of those out, and I'll show you. Actually, why don't we just go to the next slide, Jane, and it'll start to provide some more information. So I think what's cool about our data set is that, of course, we can do what I just showed you by disease. And so this here is the 3 health conditions that between 1996 and 2013 increased the most. And now we can start to take, a slightly more nuanced perspective. We know a lot about each one of these diseases. Diabetes is, fundamentally different than low back and neck pain. What they have in common is they're both leading to, an amazing amount of healthcare spending, and that the growth over the 1996-2013 is enormous. But the things that are driving that spending are really fundamentally different, right? Diabetes is a story that's mostly about pharmaceuticals. And when we look at that pharmaceutical bar, that's the really big one for diabetes, the increase is all 5 of these bars. So there's, a larger population, an older population, that's orange. The age standardized disease prevalence of diabetes has gone up, not surprising to many folks that with obesity, we see more diabetes, even controlling for age. But then the prescriptions per diabetic has gone up. That's that kind of light green, the pea green. And then the dollars per prescription has gone up, and that's that red bar. And so because we can take a more nuanced disease focus, we can start to answer the question, Jane, that I think you have, which is, well, hey, this small increase in pharmas could be driven by other things. Well, if we know there's a disease, maybe one of the cancers, where most of the pharmaceuticals are administered inpatient or in an ambulatory care setting, then we can look at ambulatory care with a slightly different perspective and understand that a major part of that is going to be the pharmaceuticals, the specialty drugs, and whatnot. And so that's what we have at the moment. I think there's always interest in asking, like, how can we make this of more utility? And hearing that breakdown, especially for specialty drugs, as a high priority is really useful.
Joe,
Can
I want
ask
to
one
just,
follow-up question?
Jane, hang on one second. Joe, I
Okay.
just want to call out for the public at large. I know we are moving into public comment period. We're a little bit over. Joe's going to be wrapping up these illustrative charts. These are just what they have for us, and these are sneak peeks for the future. This is national data. So again, there'll be so much more coming back to the board from IHME. And Jane, one quick follow-up question, then Joe, I'm going to ask you to go through your other example
Yep.
charts, and then we will move to public comments. So for the public, please just hold on for another 2 minutes. Go ahead, Jane.
Yeah, I guess, Joe, and you don't have to answer now, but a lot of interest in how you measure what that prescription drug costs, right? Is it the allowed amount paid by the payer? Does it take into consideration rebates? If it takes into consideration rebates, how many are kept by the payer? How many stay with the PBM, right? All of those questions. There's a lot of interest, I think, in that. And it's just a matter of how many of those questions you can answer with the data that you've got available, I think.
Thanks, Jane. Yeah, we have a member of our team that just focuses on the pharma side because, of course, it's a very high interest. It's also quite complicated for many of the reasons you just mentioned. And so I think we do have answers to some of those questions. They're happy to provide more information. So let's go real quickly through the last slides. So this is just to highlight that we can do this by race and ethnicity. We only can do what the data exists. In this case, we were able to use national data to make estimates by race and ethnicity. We aspire to do something at a more granular level for the state of Washington as well, as the data is available. And so this just kind of highlights that kind of first look at that at the national level. The next slide highlights, what you can start to do with that about understanding disparities. And so the y-axis here is the difference from the all population spending per capita. And this is just juxtaposing the two largest race ethnicity groups in the country, the Black non-Hispanic category, the white non-Hispanic category. And you see that the two groups have very different, relative to the mean, they have very different utilization rates in the types of care that are being utilized. And most of the disparities, most of the differences between the Black non-Hispanic and white non-Hispanic groups is about utilization. The blue arrows is what's driving this. It's not so much about price and intensity. Now, the red bars are the red price and intensity, and those are not the, non-existent, but really the story about disparities at a national level tends to be more about access and utilization than it is about price and intensity. And again, we can look at this at a disease-specific category as well. This is another project. We looked at modifiable risk factors, and we attributed healthcare spending to risk factors like high body mass index or high systolic blood pressure, those being the two largest modifiable risk factors that we can attribute healthcare spending to. I think the last slide, or maybe that's the last one. So the next steps, just to be very quick, is that we're in the process of accessing the all-payer claims database. We will also be incorporating other Washington-specific databases as they're available. That's part of the data landscaping. We do really aspire for this to be a learning exercise, both for the board, we hope, but also for our team to think about how these data can be useful. And we do aspire for it to be a dynamic process. And then by December, we need to have our analytical strategy put together and shared with the board. So thanks, everybody, for the time. I'm sorry that things maybe went a little long, and look forward to further engagement.
Fabulous, Joe. Thank you so much. We are so looking forward to working together with you and your team on this project. So board, much more to come from our IHME partners. I'm going to move us now into public comment. For those of you from the public, thank you for being patient. We welcome any public comments. Board members, I remind you that there in your board booklets are written correspondence as well. The written public comments received since our last meeting can be found under the 5th tab in your board materials, as I just reminded you. And we allow individuals to sign up to provide public comment before the meeting. And Mandy, I know, is getting people queued up. So we'll start those. Hold on, my computer's jumping around. Let's see. Mandy, you got that list ready to go. If you've not signed up and you'd like to provide public comment, please raise your hand because we're opening up the platform. And Mandy's going to call on you after we hear from individuals who have signed up. When you are called upon, I remind you to please state your name and affiliation, if there is any, before you speak. And just raise your hands once, and that just helps us ensure that we can get to everybody. And you're also, if you don't feel like speaking, I remind you that you can provide comments in writing via email at any time. And now Mandy's going to go ahead and open up that queue. Mandy, go ahead.
The first person I have for public comments is Katerina Lamarche.
Go ahead, Katerina.
I don't yet see her in the queue. I know that we weren't scrolling through to see if we could find her.
Okay, Katerina, if you can hear us and you've not unmuted or you're having trouble, we'll come back to you. So why don't we go on to
I
the
see
next?
her just now.
Oh, I'm here. Sorry. I'm here. It's a different format, so I wasn't aware that I had to join as a panelist, but it's working now. Thank you. Sorry for the
No worries.
Katerina Lamarche, Policy Director of the Washington State Hospital Association. I actually have two comments. I'll be providing one on behalf of Allison Bailey and then one of my own. Allison wasn't able to attend today due to a scheduling conflict. I think she anticipated comment being at sort of the beginning of the period as it has been the past couple meetings, but I know Wisha has addressed this in the past. Receiving the agenda so close to the meeting time does make it a little bit hard to prepare and plan for comment, but we did really appreciate that the joint advisory committee meeting materials were provided well in advance because we do want to be participatory and helpful where possible. Allison Bailey is the Associate Vice President of Revenue Cycle at Multicare Health System, and she's also a member of your Data Advisory Committee. She wanted to make the following comment that I will read now.
Katerina, before you go further, can I ask you to get closer to your microphone or adjust your sound just somewhat? You're a little bit robotic at times.
Oh, is this better?
Let's try one more. Test 1, 2, 3.
How's this?
That's better. Thank you.
Okay. Allison Bailey is the Associate Vice President of Revenue Cycle at Multicare Health System, and she is also a member of your Data Advisory Committee. Wasn't sure if you heard this part, so I wanted to reiterate. She wanted to make the following comment. At the last board meeting, the state's consultants provided an overview of how performance for providers would be measured against the benchmark. This prompted questions and the need for more information, so there's a better understanding of what this looks like in practice from the provider perspective. For instance, we don't know which providers will be considered within our network or what information, if any, will be given to providers if they exceed the benchmark. We also wonder whether there will be data at the provider-specific level. How can we verify that the information is correct? And most importantly, will the data be detailed enough for us to understand where change is needed so that we know how to improve? The data must be specific, verifiable, and actionable. It is important that there is enough information so that providers know where and how to make changes if they exceed the benchmark. Not providing enough information and not providing specific verified data will only set providers up to fail. So speaking on behalf of WSHA, I did have a few questions about the annual legislative report. Based on the agenda, it looks like you'll be voting to adopt. And I saw that there's a note that the board, that board and stakeholder feedback will be incorporated into the final draft. And you may be answering these questions when you speak on this next. But my first is whether the advisory committees will have a chance to review and provide feedback to the board. My second question is how should And lastly, and I may be interpreting it incorrectly, but it seems a little bit backwards of a process to adopt a report before incorporating feedback. But I was wondering if the board will have an opportunity to review the final draft with the incorporated feedback before it's submitted. And again, you may be answering these questions, but if not, we would like to.
So Katerina, thank you for sharing your concerns. And as we go through this process, we'll provide you the information and the opportunities to give feedback, as we always have done through these public comment periods.
Great.
And as we have more definitive information, it works through all of our advisory committees and to the full board to the best of the extent. There's always new information and new processes. Our staff were just involved in a significant national meeting of the cost boards around the nation. And so as things change, I can assure you that this is kind of a slow, steady process, and we will keep you informed as we have more information and as the board, continue to work through this iterative process. But thank you for your feedback.
Thank you.
Mandy, who's next?
We have Jonathan Bennett.
Great, Jonathan, go ahead.
Can you hear me?
Yes.
Perfect. Yeah, I am thankful for the opportunity to comment today. Like, my name is Jonathan Bennett. I'm the Vice President of Data Analytics and IT Services at the Hospital Association. I'm also a member of the Data Advisory Committee. During the April 2023 board meeting, an overview of how the performance for providers would be measured against the benchmark was shared. The overview was helpful in providing a high-level picture, but it also left us with a lot of questions, both general and specific questions to providers. A number of the questions about how providers will be measured remain, and it's still unclear to us, even if providers will be measured, which providers will be measured against the benchmark. To improve the understanding of the performance measurement process by both the board and the providers, we respectively request that the HCA staff provide a follow-up presentation to provide additional clarity on this. The advisory committee representatives introduced a motion at the June 6th combined meeting that made this request of the board. Unfortunately, the course of the meeting didn't allow for the committee members to act on this motion. Therefore, we urge the board not to wait for a formal motion from the committees, but to quickly move ahead with having consultants and HCA staff provide requested clarification. We believe it's going to be important for the board to have a comprehensive understanding of the methodology, including both its strengths and its weaknesses, since it is one of the primary tools being used to help control the cost growth. Additionally, it's imperative that providers understand how they are being measured and what information/resources they can expect to get throughout the process. As I mentioned, I've been a part of the process from the data advisory group perspective over the past couple of years, and I don't feel comfortable or confident that I could explain to a provider group how they are being measured today and what information and resources they would be getting to support them. So for us, we want to build that engagement. Then we're going to need to provide information to this group and resources that they can help understand how they're going to be measured. And the question that keeps coming back to me is there a clear path for providers to take the necessary actions if they were to exceed the benchmark? And I'm hoping that this group will consider these recommendations, and I appreciate the opportunity.
Jonathan, thank you again for sharing your concerns and sending in your written materials as well. We've discussed methodology many times at the advisory committees, at both the board and the committees, and we're going to continue. But I do want to remind everyone that we're currently working on the establishment of the baseline for the benchmark, which will not include a report out on providers and carriers initially. So in future years after the baseline, RCW 70.390 requires the board to report annually on performance relative to the baseline benchmark at the state, health insurance market, individual payer, and large provider entity levels, not the small or individual providers. So we're getting there, but we kind of, this is a journey that we're on together. We're exploring together, and as we have more information and as we're working through it together, but I think people have to remember that initially we're going for aggregate information, but thank you for those comments. Mandy, who's next?
I have Jeb Shepherd, but I don't see him in the meeting, and we didn't see him in any other formats.
Okay,
Second, just in case.
Jeb, if you're there. Not seeing him. If he jumps on later, we'll recognize him towards the end of public comments. Is there another person in the queue?
I do. I have Jim Fraber.
Great, Jim, go ahead.
Hi, I'm Jim Freiberg from the Patient Coalition of Washington. I'd like to offer some quick encouraging comments on the board's work from the perspective of patients. I want to offer my support for the deep dive that the board is doing to understand cost drivers and urge you to proceed as quickly as possible to offer policy solutions. Consumers are continuing to be hurt by high healthcare spending, and there appears to be no relief on the horizon. As one indication of the growing nature of this problem, I'm sure you're all aware of the recent proposed health insurance premium increases released by the Insurance Commissioner's Office, and we know more significant increases are coming in future years. The incredible variation in care cost and quality that we all know exists mean there's significant room for improvement, and we need the board to offer relief as soon as possible. I hope we don't get stuck on methodology and instead can move forward with real action items. It's not easy work, but it's not impossible. I'm optimistic that IHME's insights can help us get there sooner rather than later. So thank you for your continued work.
Jim, thank you for those comments. Mandy, who's next in the queue, please?
I don't see any other hands raised, and I have no other names signed up.
Great. And Jim, I do want to assure you that the board is moving as expeditiously as possible, really trying to be inclusive but sensitive and giving kind of the proper time for people to process and come along on this exploratory journey. But we certainly are tracking nationally what other states are doing and trying to glean insights and move this along as quickly as possible, because we too are very, very concerned about the ongoing unaffordability and cost issues. All right, at this time, and I don't see Jeb that he has jumped on, we are going to close public comments. Thank you, board members, for letting us intersperse those comments in.
I have a comment, Sue.
Oh, I'm sorry, Ronnie. I didn't see your hand up.
And Mandy actually recognized me and
I do recognize you.
Could you, I'm sorry, so we will reopen public comment. Could you identify yourself and go ahead, Ronnie?
My name is Ronnie Shore. I'm the president of Healthcare for All Washington, and I wanted to just support, like Jim did, the comment or the use of IHME. Looking at comprehensive data can actually point out a number of issues. And someone from IME, in the example I'd like to share is that someone from IHME joined a discussion about universal healthcare in other countries, and they were able to point out a number of demographic, or by pulling in this broad variety of data, they were able to help us understand why healthcare services may be needed more in certain areas and how that lessons could be learned for our state and our country. So I just wanted to compliment that use of analytics data support. That's all.
Thank you for those comments, Ronnie. The board is keenly aware of comparisons. And again, I do think the collective national and international efforts are really compelling, because we just simply can't waste money any longer, and we have to continue to look at value. So with that, I'm going to get us back to our board agenda, because we still have some significant ground to cover. And we truly thank the public for those comments. They're very important. So please continue to send them in, and we will continue to work with you. Margaret, I see your hand up.
Yes, thanks, Sue. We've been getting regular letters from the Hospital Association and the Medical Association, very thoughtful letters. And as a board member, it's not clear to me what happens as a result of that kind of input. Whether the HCA staff makes some changes or agrees with it or doesn't agree with it. So it would be helpful to learn more about what happens as a result of that input.
Great, thank you, Margaret. I know this last set of articles that WISH has sent out and some of their comments, we can certainly look at a process of how we might want to include the board in some of that process. So we'll get back to you on that.
Thank you.
Thank you for that input. Let's move on. I'd like Mandy, Laura Kate Zeitchen, and Kristen Villas. They're going to provide us with a brief overview of the draft legislative reports And these are under tab 6, and we have the slide presentation up. So go ahead. Mandy, Laura, we're going to talk about Cascade Select Public Option Report.
Thank you, Sue. Next slide, please. I think you might have gone one too far. Oh, I'm sorry, you're right. Good afternoon, board members. I'm excited to work with the board in my new role. And I'm here today to present on the draft report of the Cascade Select report. That's also called the Public Option Report. Joining me today are my fellow presenters, Laura, Kate, and Kristen from the Health Benefit Exchange. And today we'd like to provide you with an overview of the report so that we can get your feedback to incorporate it in the final draft. We'll also follow up with you with a Word version of this report in case some of you might write to provide feedback via writing. We just ask that you provide any feedback by July 6th. The timing for this report is critical and fast moving because it is part of a series of reports. HB and the board are both working on draft reports at the same time. HB's report is on the impact of public option plans on hospitals, while the board's report is on the impact of the public option on consumers. When both of these reports are complete, HB will take the two reports and create a sort of third report or recommendations for the legislature, and those recommendations are due by December the 1st. Next slide, please. The goal of the public option is to increase the availability of affordable quality healthcare coverage to all Washingtonians on the exchange. To ensure achievement of these goals, the legislature has asked the cost board to look at the impact of the public option on consumers in the state of Washington, including the critical elements to consumers like benefits, premiums, and cost sharing for consumers. The legislature has not requested that the cost board create recommendations out of these, but rather assign that role to HB in that third phase for them to take these reports and then bring those to stakeholders to create their recommendations. Next slide, please. To initiate this report, HB and HCA identified the various data sources that are available in the state of Washington for the board's use in the draft report. And back at the February meeting, we gave an outline of these draft resources that would be utilized. We also invited board member feedback at that February meeting. Following the February meeting, we sent a survey around to the board members asking if they had any additional thoughts or questions that could be included in the report. And so after the February meeting, HCA staff and HB staff reviewed the board member feedback, gathered the data, performed the analysis, and then drafted this report that we have included for you in the packet. Next slide. Thank you. Based on board member feedback from the survey, members were highly aligned with the legislative request, specifically on premiums and cost sharings. The board was also highly interested in access to care as an issue, and members also identified other areas of interest that they were interested in, including in the draft report, such as drivers of enrollment in public option plans, qualitative data from consumers, and drivers of variability in public option premiums. One of the more difficult elements of this report is the somewhat limited data. The public option has only been around for 3 years. And so trend and impact data is a little difficult because of the shorter time period. However, we've examined and utilized all of our resources available to create this report. One slide back, please. Thank you. Working with our partners at the Health Benefit Exchange and the Office of the Insurance Commissioner, we drew from our own areas of expertise and our own reports that we currently have filed with regards to the public option. And we reviewed as much publicly available data as possible. On this slide is a sampling of the data that was utilized to create the report, such as the enrollment reports, the rate filings, and the previous reports filed with the legislature. I'll hand it off now to Laura Kate and Kristen, our HCA partners in the public option, and they'll address some of the concerns that the board members included in their board member surveys.
Thanks, Mandy.
You.
Hi, everyone. I'm Laura Kate Zeichkin. My pronouns are she, her, and I am with the Health Benefit Exchange. It's been great to work with HCA and the board on this, and we're looking forward to presenting some of the draft analysis. Before we dive in, and we can thank you, we can go to the next slide. I just want to make sure we're all clear about sort of what we're talking about here when we talk about public option, when we talk about its benefit design and some of its affordability levers. So before I hand this off to Kristen to share some of the results of the draft analysis, I'm going to provide an overview of Cascade Care and public option within it. So Cascade Care really exists because, as this board well knows, many Washingtonians don't get the health coverage or care that they need because it's too expensive. So the state's Cascade Care effort really aims to make sure that health coverage is accessible and affordable for every Washington Health Plan Finder customer. And as you can see on this slide with Cascade Care, the exchange offers Cascade Care plans, and that's what we're going to be focused on today and what the analysis is focused on, and then also Cascade Care savings. So unlike non-standard plans or non-Cascade Care plans, which are designed by the carrier and can vary in deductibles and copays, Cascade Care plans are designed to have the same benefits regardless of, which insurance carrier is offering them. They also cover more before the deductible, and they're only available on Washington Health Plan Finder. Some Cascade Care plans are called Cascade Select plans, and these are the state's public option plans. These plans provide higher quality and more savings to customers, which we'll talk about today. And then what we're not focused on today, but is included in the report as context, is Cascade Care savings. So based on household income, Cascade Care Savings provides additional financial assistance to lower the premium cost of Cascade Care Silver or Gold plans. That includes public option plans. And if we go to the next slide, we'll talk about what those public option plans are. So these Cascade Care plans are high quality. Are we moving to the next slide, or can I just not? Thank you. So Cascade Care plans are high quality, low cost, standard benefit plans. And these, as I said, are available exclusively to Washington Health Plan Finder customers. All Cascade Care plans let customers pay less at the doctor's office with more predictable costs. These have the same benefit design that makes it easier for folks to shop and compare plans from across different carriers. And it really provides this apples to apples comparison so customers can focus on premium costs and whether their doctors are in network. When we talk about public option plans and their benefit design in this analysis, I really want to note and highlight that public option plans are Cascade Care plans. Public option plans are these QHPs that are designed by the exchange with the same benefit design and then selected by the healthcare authority. So these provide the same predictable benefits as all other Cascade Care plans. So when we talk about plan design and cost sharing for Cascade Care plans, we're talking about public option plans. And I will just briefly on the next slide talk more about public option and its specific policy levers as they relate primarily to affordability. So if we go to the next slide with the chart, you can see here that in addition to standard benefits, carriers are required to meet higher quality standards and state-defined reimbursement rates for providers when they're offering a public option plan. Additionally, as of 2023, hospitals are required to contract with at least one public option plan. So when we look at the goals here of affordability and statewide access and quality and equity, you can see the policy levers that include the reimbursement requirements, the hospital participation requirements, the competitive procurement by the state, and then those additional quality and value requirements as well. And through all of this, the healthcare authority can really be more selective in its competitive contracting with exchange carriers who are interested in competing to offer public option plans that are the highest quality and lowest premiums. And this really promotes healthy competition on the exchange and lower premiums for Washingtonians. So with that Cascade Care overview, I'm going to turn this over to Kristen Vias to provide an overview of the analysis that you have in draft form here today.
Good afternoon. I'm Kristen Vias, HBE Senior Policy Analyst, and going to do a quick overview of our findings on both public option premiums and cost sharing. Since the introduction of public option plans, we've had significant growth each year. At the end of our latest open enrollment, 11% of exchange customers are in a public option plan. And here's some key information. Public option enrollees, we know that new enrollees are more likely to choose a public option plan. And thinking about demographics, we see the public option enrollees skew younger than those in non-public option plans. And while some trends in enrollment by income vary by year, we saw a greater proportion of lower income enrollees in public option in 2021 and 2023, but we didn't observe that same difference in 2022. Next slide, please. Lower premiums are a major driver of increases in the public option enrollment we've seen. A primary goal of public option is to meaningfully lower premiums for customers statewide who are purchasing coverage on the exchange. This affordability goal has not yet been met. However, we do see promise in public option plans having more affordable premiums relative to other plans. As you know, the informal target for meaningfully lower premiums in public option plans is those plans being 10% lower than the next lowest cost premium plan. While we've seen this in a few counties, the target has not been met for the program as a whole. And so what we've seen in the first few years is that the public option plans were initially higher, but they have consistently trended downward at all metal levels. Also, they are the most affordable health plans on the exchange in many counties. HC's competitive and selective procurement in 2023 compared to a process the first couple of years that allowed all interested carriers to offer public option was really a key driver in 2023 in terms of the advancements we saw with affordability, availability, and healthy market competition. In 2023, public option plans are the lowest cost silver plans in 25 counties. This is up from 13 counties in 2022. Additionally, when we look at average premium increases over the first few years that we have, the public option rates decreased by 6%, while the non-cascade plans increased by more than 15%. So these are really promising signals that we can offer folks a comprehensive set of benefits at a lower premium when we pair that with active procurement and requirements that address underlying cost drivers of premiums. Next slide. Turning to a comparison of public option cost sharing compared to non-cascade plans, what we found is that the benefit design has enrollees paying less out of pocket when they use their care. The cascade plans feature low cost sharing for high value services such as primary care. So that's set at a copay prior to the deductible, regardless of the number of visits the enrollee has. And this is the case for all metal levels of the plan. We found deductibles are $1,000 less on average than non-cascade plans. And when we looked at trends about what impact cascade plans had on the exchange as a whole, is that we saw the average deductibles for non-cascade plans at the gold and silver metal levels came down significantly when we introduced the lower deductible Cascade plans on the market in 2021. And what you see on this slide is a sample cost breakdown of a childbirth, comparing the Cascade Silver to a popular non-Cascade Silver plan. So because many of the Cascade Silver benefits are pre-deductible and at a fixed copayment, the enrollee ends up paying over $3,000 less for their care. Next slide. So looking at some important customer impacts, we found that public option plan enrollees are selecting plans with more generous coverage, but narrower networks for public option plans and also maintaining affordability amidst rising premiums are challenges. So with the introduction of premium affordability measures paired with public option plan premiums are lower than other plan types. Exchange enrollees are selecting plans with richer benefits. So we had enhanced federal subsidies starting in 2021, and also the introduction of our state subsidy, Cascade Care Savings in 2023, made it possible for people to be able to enroll in a more generous plan. So compared to non-public option enrollees, the public option enrollees, more of them are in a silver or gold plan. And that's, interestingly enough, a trend we saw even before Cascade Care Savings became available in 2023. Considering some challenges, some of our watch points are narrower networks and access. So we know that exchange consumers face choice overload. So folks in some counties still have a choice of 50 plans, which is a lot. And research shows when enrollees have too many plan choices, they might not make the best choice, or worse yet, they could get so overwhelmed they choose not to enroll at all. And so Cascade Care plans aim to offer meaningful choice. So by offering the same benefit design, it's easier for customers to do apples to apples comparisons. And when we look at public option networks, provider participation has definitely had an impact on consumers enrolled in public option because the provider networks are different than non-public option plans. So of course, every plan on the exchange meets OIC network access requirements. However, public option plan networks rely on provider participation. And as the networks are different and often not as extensive compared to those non-public option networks, folks have fewer choices. So we have had some reports of customers having confusion, trying to navigate the different networks, especially if they switch from a non-public option plan to a public option plan within the same carrier. So access to public option has been growing, which is wonderful. It's not yet available statewide, but in 2023, it is now in 34 counties, up from 25 in 2022. And so based on the initial filings we have for 2024, public option plans will be in a couple more counties, but still not yet available statewide. And, our exchange carriers who are offering public option plans say that they, really want to offer this available to consumers statewide. And so this really, relies on those partnerships with healthcare providers. And agreeing to participate in the public option networks to those reimbursement rates that will help us meet those state affordability standards. And this has been challenging. So we've definitely made some progress, but carriers still report that some providers will not agree to participate in their public option networks. Despite some good gains, access and affordability are really fragile. We know that the exchange premiums are increasing annually at much higher rates than the state's cost growth target. And additionally, public option premiums still cost an average of almost $400 a month, which is a lot when you compare that to folks who may get coverage from an employer. And a lot of exchange consumers rely on federal and state subsidies to be able to pay these premiums and still meet their other household expenses. The enhanced federal subsidies are going to expire in plan year 2026. So this is going to have a big impact on consumers being able to afford their premiums. Also, we still want to continue to address these barriers and risks to customer access and really maintain and strengthen our public option tools to achieve our goals of those meaningfully lower premiums, provider participation in public options statewide, and really having high quality and meaningful plan choice. I know that was a lot. If we move to the next slide, we can go ahead and take some questions.
Thank you, all three of you, for that information. And congratulations, what great progress. Leah, I see your hand up first, and then Eileen Cody.
Hi all, it's a pleasure of being the delegate for the Health Benefit Exchange today. And congratulations and thank you to both the Healthcare Authority and OIC for our partnership in public option. I just wanted to add a little context for the board that isn't steeped in it, and really appreciate the board's attention to this, 4% corner of our Washington market. As was noted earlier, we're facing this year an almost 10% rate increase that was proposed. And this supports individuals and families that don't have access to either a government funded, mostly Medicaid or Medicare, or group health, primarily through employer insurance. So they're facing the entirety of that burden, although there are subsidies that all of us are paying taxes on to help support them. So I think it's really important that the cost board was given this task to look at the consumer impact. And we see some really promising signs, or at least I did in that data. So I guess I would encourage the board to think about, our role here on the cost control board in terms of bending the cost curve. This is not reducing costs out of the system, it's bending how much it goes up every year. And I think we've seen that, some promising steps in public options. So how could we think about this innovation as one model? I'm not suggesting that it would become a recommendation of this board or be a lever that's applicable in all other models, but I really think it's one of the unique places where we're starting to see some trend change. And I would encourage us to continue to think about the positive impact it could have on slowing this trend, especially if that continues, while we've been able to improve and enhance the cost sharing for at least our customers.
Thank you, Leah. It really is remarkable. It's just one of the many tools we have in our belts, and we don't know all the tools that are coming ahead of us, but it is one that is moving in the right direction. So I would agree with those comments, and thank you for that input. Eileen Cody, I bet you have some comments to make.
I have some questions for the exchange. In the percentage of people that are buying the non-standardized plans, do we have the ability to have it broken down by income level? Because people with more disposable income may choose to buy those plans with the high deductible because they're paying less out of, especially if they're young and healthy. They have a tendency to think they're immortal. So I just was curious if we could do that. And then the other question I have is on the counties that still do not have the Cascade Care Select, the public option. The hospitals did the plans let us know what the problem has been? Is it the hospitals that hospitals had to participate, so I'm assuming it's providers, the practitioners. But I'm just curious as to, or do we have some counties that don't have a hospital in them, which yes, we probably do. I'm just curious if there's been more evaluation on that.
You are currently investigating that. And I'm sorry, do you have your hand to your ear, Eileen Cody, Representative Cody? Do I need to speak up?
No, that's all. That's fine.
Okay,
I got you now.
Okay, we are currently investigating that, and we should have some information I'd be happy to share with you later.
And what about the non-standard plans?
Yeah, we certainly can share information about the income breakdown and even just sort of characteristics of those enrollees in non-standard plans we actually have another report to the legislature about the impact of eliminating non-standard plans on the market. And as part of that, we're doing a really big deep dive into plan characteristics and enrollee characteristics. So we can definitely apply that to this analysis. I don't know, Kristen, if you have anything off, like in front of you about those enrolled in non-standard plans.
Legislators always have a bunch of questions. What can I say?
Yeah, if memory serves from our first look, it was folks who were older and then also lower income.
Kristen, did Kristen freeze up or is it just me?
Kristen is not frozen for me.
Okay. Jane, do you have a question?
Yeah, so in terms of, to follow along with Eileen's question and sort of the demographics of the folks who are choosing non-standard plans, I think it would be really helpful, and thanks to thank you, Kristen, to pointing out the issue around narrow networks in public option plans, is when we look at non-standard versus standard, what do the networks look like? And do we have significantly broader networks for the non-standard than the standard? That would be helpful information. And then also just a note to the board is there is still a small group of folks, probably between 20 and 30,000 folks, who buy their coverage off the exchange. So I think where OIC is happy to help in terms of trying to get some data if you need it to around, if we can, around who's buying off exchange versus on exchange to try to help inform the work.
Jane, thanks for that. We can definitely include more information about networks as it's available in the report. To your question about networks in non-standard versus standard, the networks, what we've seen is that networks are the same between non-standard and standard plans. It's the public option networks that are different and narrower is what we believe.
All right, I'm going to move us along. I believe the board is there a motion to adopt the public option report with the understanding that the board and stakeholder feedback will be incorporated into the final drafts? Because we definitely, this is a body of work that we are overseeing.
I will make the motion.
Thank you, Lois. Is there a second?
I'll second, but I was just going to question, will the board get a copy so that we can give our feedback from the feedback that's coming from the others?
Yes, we will
Okay.
get a copy out to you as soon as we compile all of the information.
All right, okay. Thanks.
So we have a motion and a second, and Eileen, thank you for that discussion. And board members, we want to keep this on track so that it's a bit open-ended, but we want to get the staff kind of moving so they can get the final draft back to us. But then knowing that it will include the two components of the stakeholder feedback and any further information, it will get back to us. Is all in favor, say aye.
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 Any opposed? Okay, the motion approves, and staff, you will get back the Cascade Select report to us in its final form, but please proceed with getting that work finalized. Let's go ahead now. In your materials under tab 7, you're also going to find a draft of the board's annual report to the legislature, and this summarizes our activities for the past year. Mandy?
Yes, we've included this report for your consideration and vote. It's just a summary of the items that the board has worked on. And so we didn't create a slide deck for it, knowing that we are very short on time at this particular meeting. but we just wanted to provide it for you. We will also follow the same process. If you'd like to provide feedback, we will take feedback. I'll send out a Word version of it to the board members. We'll take feedback and comments and we'll incorporate that and send it back out as the final draft for everyone's review.
Okay, so again, oh, go ahead, Margaret. Margaret, I think you had a question.
Yeah, so just to clarify, I remember last year with the report to the legislature, there was some concern after the report was submitted about some of the language that was used. And I think it was because people didn't have a chance to give their feedback and see that it was incorporated. So we just got this report yesterday afternoon, so it was very difficult to give it much attention. And I'm a little worried about voting on it now without being assured that after all the feedback is in from the various stakeholders in the board and so on, that we'll have a chance to review and act on it rather than just having it go in once the staff is satisfied that they've dealt with the feedback.
Oh, yes, just to reiterate the process. We'll allow until July 6th for any comments from the board members. We will include all those comments. We'll send that back out to the board members for their final review. And then we will submit it.
And so what happens after the board reviews it again?
We'll
Will
ask
they
if there's any concerns.
but there won't be another vote.
Hopefully not. Hopefully we won't need one if there aren't any concerns.
Margaret, we're giving the staff the authority to develop these reports with our final written draft review via emails. But we're giving them guidance to go forward, prepare these and get them back to us so we can provide additional comment and detail anything. So because we won't be meeting again before these reports are due, we need to get them in motion, authority to stay in motion and to incorporate the feedback. Does that make sense?
Yes, I guess I would request that in the future, I would really like to see the final report after all the feedback is in and then have the board take action then.
We will take that under advisement and see if we can make that work depending on when. I know, for example, with the dates and the information coming in, it just is tight to make that work, but it certainly is optimal as you've suggested.
Thank you. I understand.
Great. Other comments before we move on? All right. So is there a motion to adopt the annual report with the understanding that the board and stakeholder feedback will be incorporated into the final drafts? This is resolving Margaret's comment that she just made.
I'll make the motion, with the understanding that we will get to review.
Thank you, Eileen. And any further discussion?
So I think a friendly amendment would be, and if there's something that a board member feels is unresolved, it will need to come back. Which I think I heard Mandy say, but I just want to include that in the process. I have faith that it won't need to, but.
Thank you for that clarification, Leah. So Eileen has made a motion with that friendly amendment, I believe. And is there a second?
I'll second. This is Leah.
Okay, all in favor, say aye.
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 Any opposed? And that motion is approved. All right.
Sue, this is Jane. I'm sorry. I'm not opposed, but one thing that might be helpful to help facilitate board review of the next version of the report is if we could get a copy that just shows in-track changes where revisions were made to the current version of the report.
Thank you, Jane, and I'll ask staff to send it out that way.
Thanks.
Great. Okay. Finally, we've got Dr. Zerzan. Judy, I know you're here to review the primary care committee's recommendation for primary care claims-based measurement. Do you think you're going to be able to cover this in our short 10 minutes?
I think I am willing to try because I am on vacation during the next meeting. So, yeah.
Have at it. Everybody, Dr.
So buckle up.
Our chief medical officer.
Yes. And I can always answer questions afterwards. So I guess, I don't know. So the primary care spend committee has been very active, as you know. We have a definition that was modified slightly from what we had before. We also have worked on the who. We have a finalized definition of that. The what, which is, we don't have the exhaustive list of codes because it really is quite a lot. It's lower than, oh, here we go. So we have these sort of 3 buckets I'll walk you through quickly. So next, and next, and next. Look at how fast this is. So there's the who, what, where. There is the definition of primary care. And we added to the goal of physical, mental, and social health in the general well-being of each person. I really like this definition. So it's our North Star. Next slide. So one thing that we have been talking about a lot is this broad versus narrow definition. This was set up in the initial report of spend by the Office of Financial Management, and we have continued to go in that path. Most other states have not gone in this broad versus narrow path. And so we're going to keep talking about whether we need both broad and narrow or whether to keep it. But I wanted to let you know that's a conversation we're having. Next. So this is the narrow definition of who provides primary care. There shouldn't be any surprises there. And the next slide is the broad definition of primary care. So you can see that behavioral health is added in for behavioral health integration. OBGYN is also in there, and then a couple of additional specialties that sometimes do primary care and other things. Next slide. This is the where, so all of these sites. I think one of the things that we're going to do, the next piece that is going to be done in this work is to review the data. And most other states also do not include the where. We did not include the where in the OFM definition because the location of services is not included in the APCD. And so we are looking at other sources and whether this is accurate or not. TBD whether the where stays in there, but this is our list. Next slide. And as I said earlier, there is a laundry list. There are most states down in a smaller set. Colorado and us are on the other end of that spectrum with a much wider set of codes. Through this process, we've moved Washington down a little bit from where Colorado is, but we are still pretty different from other states. There are both some advantages and disadvantages, I think, to being different from other states. So our next step is to review the data in the codes, and for codes that aren't used very often or that we can't tell if they're specialists or primary care, we might consider removing those. So in the next few months, I'll probably be bringing back that information for you to review. Next slide. So we included a couple of things in the Ledger report just because we wanted to get these ideas out there in the conversation and start socializing some of them. None of these are hard recommendations of things to do, but in the thought of how do we support and measure primary care and how do we increase spend in primary care, the committee reviewed a number of strategies. This is the ranked list of those strategies that got support, and it is in order. of what got support. And so the EHR is a service, which is one thing that we are embarking on this year, electronic consent management, the One Health portal, the APCD, all of these things are tools that will be helpful to measure the claims and non-claims based spend. Next. So this, I wish I had more time to talk to you about, but I think, you know, all it is thinking right now. So the ultimate goal is to get access to high quality primary care, and 12% spend is a lever to support this goal. And so we've created a 4-domain framework to think about different strategies to get to 12%. Next. And these are those strategies. So first is sort of obvious direct investment. So pay more for codes that are primary care, or pay more for primary care services. Next is capacity growth. So this includes workforce investment and reducing barriers on administrative activities. So more time is spent on patient care. Patient behavior. So how do we get people to use primary care services, and then reduce expenditure on other services? So maybe use of the ER, urgent care, for example, is used less because people have access to their primary care. And so to get to our 12% target, we're going to need all 4 of these domains. And so the committee did a similar exercise of different strategies that they thought were helpful. Most of these have the bucket, those 4 buckets that it's in. And again, this is in rank order of the committee's thoughts of the different strategies that they supported. So number 1 is not super surprising, increase primary care reimbursement and capacity growth, decrease admin burden. Admin burden was certainly has been a conversation for a while, and was a focus this legislative session about prior authorization and some other things. And so these are ideas that we're not asking you to adopt, but that we are going to talk about more. Next slide. I think that yeah, and I'm not sure if there's a next step. Yes. So our next meeting next week, we're going to start talking about the non-claims based collection policy. And then hopefully in July, we will start looking at the data analysis to finalize that code set and bring it back. I suspect that's going to take a couple of months. And then September through December, we're going to make a plan of how we implement that and talk about these strategies that we listed for you today. I think maybe that's all. Ta-da, 1 minute.
Judy, thank you for those recommendations. Amazing how your group has continued to develop this work. Is there a motion to adopt these recommendations on primary care claims-based measurement?
I will make a motion.
Thank you, Lois. Is there any discussion?
Judy, are you asking for adoption? I thought you mentioned that your team was, the advisory committee was continuing discussion on it.
We are continuing discussion on it. I think, I guess I don't know the procedure about whether there needs to be adoption, and the ledge report that you have has these strategies in there as options that the committee is thinking about. So to the extent that you guys need to approve what goes into the ledge report, then maybe you need adoption. But there is language around that these are not final recommendations, but given that we weren't going to have another opportunity to present some of these thoughts to the legislature, we really wanted to start thinking about it, which is why we spent a meeting sort of talking about the framework and how we might start to work on a 12% goal.
And though you are asking for adoption of the claims-based measurements, correct? Because that is complete.
So we actually are going to come back after we look at the data and make that complete and final. These are our draft recommendations. And we are going to come back one more time with finalized after we look at the data to inform, are there things that just don't need to be included because volume is so low? Is there any gaps? Is there a provider type or a code that we really missed that we need to look at? And then the location question. Those are the three things that we're going to look at in this data analysis.
So I think then it sounds like since it will be coming back one more time to this full board packaged up, I think we don't need any formal adoption today. This really is, you're really sending in your legislative progress report on your primary care effort. Okay.
Yes, and telling you that there's no surprises.
But if, you know, I don't think it's a bad idea though for the board to codify that we've heard this and received it. So I leave it up to.
We have included it in the board report. So it is part of a good discussion so that the board is comfortable including this in its legislative report, that it's under tab 7.
Is it something that we can give feedback in the manner that we just discussed, since we did approve the report with this content in it, with the understanding that we would be able to provide feedback and it might change?
Yes, correct.
Okay, so Eileen, do you want to let your motion stand and we'll proceed?
I was the second, but yes, that's.
Oh, I'm sorry. Lois was the first. Lois?
Yes, I do.
Thank you. Eileen, you're the second. All those in favor say aye.
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 Are there any opposed? Okay, the motion is approved. Thank you all, everyone, for attending. Thank you to our presenters. I remind the public that the recording and summary of this meeting will be posted shortly on our website. Our next meeting will not be until October 18th at 2 p.m. In the meantime, we'll be getting more staff members on to assist with the work of the board. We're going to be starting that analytics support initiative, so you'll be getting a steady feed of articles and readings that we will also publish on our website. I mentioned earlier today that I listened in on the Millbank trends in financing and ownership of US. I'll be posting that recording as well. Let me just restate too that we are canceling the July meeting because it was originally scheduled for report feedback, but with the timely presentations and managing feedback via email, we will not need to meet in July. And I hope you all have a restful, productive summer, and we will see you at the next meeting. And as always, feel free to contact any one of us and we'll be reaching out. Thanks all. This meeting is adjourned.